The first thing to keep in mind when discussing concussions is that a concussion is a traumatic brain injury. Regardless of what definition you use, in all of today's medical journals, you will see the terms concussion and mild traumatic brain injury used interchangeably. Again, I want to caution you with regard to the word mild. Brain injuries, when they are first diagnosed, are on a continuum from mild to severe. And simply because a physician uses the term mild doesn't mean that the symptoms and the residuals aren't serious. Why should you care about mild traumatic brain injuries or concussions? Well, from the CDC, we can see the number of traumatic brain injuries that occur every year. There are 52,000 deaths on average from traumatic brain injuries, over 275,000 hospitalizations. The point to take home from this slide is that there are over 1,300,000 emergency department visits for traumatic brain injury, and even more that for people who don't even receive any type of medical care or receive some other medical care other than being seen in the emergency room. And so therefore we know that over 2 million people a year suffer what is termed a mild traumatic brain injury or a concussion. And we know that the leading cause of traumatic brain injury is motor vehicle accidents followed by falls. So what is a mild traumatic brain injury? Well, the first definition, the consensus definition, was established by the American Congress of Rehabilitation Medicine in the early 1990s. They defined mild traumatic brain injury as an injury where a person has had a traumatically induced physiological disruption of brain function, manifested by at least one of the following: any alteration in mental state at the time of the accident, feeling dazed, disoriented, or confused. So it's important to note that one does not need to lose consciousness in order to suffer or sustain a mild traumatic brain injury. And so when a client comes into your office and you're looking at an emergency room report or an ambulance run sheet, you're looking for terms like dazed, disoriented, confused, all which are used to establish and diagnose a traumatic brain injury. Now, it's also not necessary that the head be struck or that the head strike something. One can sustain a traumatic brain injury just by undergoing an acceleration, deceleration movement of the head, that flexion extension injury that we often see with our clients who sustain neck or back injuries. Now, people who sustain a traumatic brain injury have three different types of symptoms: physical, cognitive, and behavioral. Physical symptoms can be nauseousness, vomiting, dizziness, headache, blurred vision, and fatigue. Cognitive deficits include attention, concentration problems, perception problems, memory difficulties, speech and language problems, or a reduction in executive functioning. Finally, behavioral changes, and in my estimation, this is that area which is most overlooked by clinicians. Patients with traumatic brain injury will have problems with irritability, quickness to anger, emotional lability, and disinhibition. Now, there's been some controversy with regard to the definition of mild traumatic brain injury. I know you all can't read this slide, but in 2007, the United States Department of Defense came out with its own definition of traumatic brain injury, and it pretty much mirrors that of the definition I showed you earlier from the American Congress of Rehabilitation. I recommend for all of you who are representing patients or clients with traumatic brain injury to obtain this little brochure from the Center for Disease Control, Facts for Physicians. You can download it. It has a wonderful list of all the signs and symptoms, and as you can see here, they break them down into physical, cognitive, emotional, which includes behavioral, as well as sleep problems. Now, many of you who have represented individuals with mild traumatic brain injury know oftentimes the emergency room report doesn't show any loss of consciousness, and oftentimes the diagnosis of concussion or brain injury is not even made in an emergency room. However, should not be enough for you to just disregard that your client may have suffered a traumatic brain injury. In a paper published in the Archives of Physical Medicine and Rehabilitation, August 2008, the researchers looked at the accuracy of mild traumatic brain injury as diagnosed in the emergency room. What they found was startling. They found that 56% of mild traumatic brain injury cases identified by the researchers did not have a documented mild TBI-related diagnosis in the emergency room records. That's telling you that in 56% of the time a patient is seen in the emergency room, the doctors and triage nurses there will miss the diagnosis that a concussion or a traumatic brain injury occurred. So again, why should you not ignore this injury? Well, first of all, what we know is that not everyone who has suffered a concussion or mild traumatic brain injury gets better. The slide I'm showing you here is from June 2000, published in the British Medical Journal. It's an article by Sir Graham Teasdale, a neurosurgeon from Glasgow, Scotland. Dr. Teasdale was one of the developers of the Glasgow Coma Scale. But Dr. Teasdale and his colleagues were looking at disability and traumatic brain injury. Their hypothesis was that people with severe traumatic brain injury would have higher rates of disability than those who had suffered a moderate traumatic brain injury, and certainly would have suffered greater disability than those who had a mild brain injury. However, what they found was that survival with moderate or severe disability was as common as those who had suffered mild brain injury, and that the incidence of disability in young people and adults with a mild brain injury was higher than expected. Now, 5 to 7 years later, Dr. Teasdale went back and looked at those people he had looked at in the year 2000. In an article published in the Journal of Neurology, Neurosurgery, and Psychiatry, published in 2006, Dr. Teasdale wrote in conclusion, admission to hospital, even after what was judged conventionally to be a minor head injury, is followed 5 to 7 years later by disability in a high proportion of survivors. Both persistence of disability and the development of new disability are associated strongly with psychosocial factors that may be open to remediation even late after injury. More recently, in 2010, at the International World Brain Injuries Association's World Congress on Traumatic Brain Injury, Dr. Teasdale again presented. We are now 10 years, a full decade since his original publication, and he spoke and presented indicating that still 10 years later, patients who had suffered a mild traumatic brain injury were still having residuals and a high rate of disability. In conclusion, I think it's important to appreciate from a patient-based perspective this slide created by Dr. Ron Roof, a neuropsychologist from San Francisco. But as you can see, the interrelationship between the physical, the cognitive, and the emotional problems that one suffers as a result of a traumatic brain injury can disrupt the entire life of that individual. From work, from home, recreational, financial, can destroy the entire meaning of life for that patient. So in conclusion, concussions from mild traumatic brain injury should not be ignored.